As Dr. Grelo is taking the podium, I just want to say first that on Friday at 3:30, our Breast Surgery International colleagues are meeting along with people from American Society of Breast Surgeons and anyone else from the surgical crowd who's interested in talking about sidebar projects that will be available on Friday. I also just want to say about Dr. Grelo, whom I've known since 1994 when I started at the University of Washington. She's been a fabulous colleague. She's a professor of medical oncology at the University of Washington. She is the director of breast medical oncology at the Seattle Cancer Care Alliance. What is really often unknown about her and unstated is the work that she's done internationally. She ran a trial in neoadjuvant chemotherapy in a project in Ukraine. I've learned a tremendous amount from her, and her advocacy work throughout the globe and the meetings that she's run are really just phenomenal. I think she's just a great attribute to the international breast community. Dr. Grelo.
Thanks, Ben, and congratulations on the 4th PHGI conference. And it's fun to see some of the drivers and the participants in several of those breast cancer advocacy conferences in Asia, Eastern Europe, and Central Asia as well, who are here at this conference. So now to introduce our next topic, we will have Dr. Fernando Perry. Dr. Perry is the Chief of Service of Breast and Soft Tissues. He's an oncology surgeon. He is at the National Institute of Cancerology in Bogota, Colombia, and the title of his presentation is Access to Hormone Receptor Testing and Other Basic Diagnostic Pathology Services in Colombia. Thanks.
Well, good morning, and thank you for the invitation to this presentation. I want to share you this subject that is a bit difficult to find literature, especially in our country, but we found something that can be interesting. This is the incidence of breast cancer in our country. Our country is in intermediate incidence. This is the last publication of the National Cancer Institute in Bogota. And you see that breast has reached the first place in incidence and almost the first place in mortality. And this is a tendency, that we have seen in our population registry of Cali in Colombia of cancer. So breast cancer at last is now really a problem for our country. This is the number of cases, new cases we see per year in our institute. This is an interesting date because we had in 1990 we had less than 1% of in situ. Now we have 4.7%. It's interesting because our institute is a hospital of reference of the most poor people in Bogota. So even those poor people, we're getting now 4.7% of in situ. We first tried to define what would be the basic pathological report for Colombia. So we looked for ASCO and we looked for these other groups that are very important. And all of them consider that these three items should be included in every pathological report. Of course, a basic pathology report must include the classic dates that we all know. And we have this question here: is it important to have a histological type of cancer nowadays? And we think that probably it would be not very interesting because histological type has been losing importance as a risk or as a factor that is important for therapeutic decisions. In 7 cities in our country is now performing sentinel lymph node. And of course, if there are a number relatively important of sentinel lymph node, we thought that there should be also a basic report pathology for this particular situation. So these are the items we think this basic pathology report in sentinel lymph node should have. And here we have a problem. That is the micrometastasis, because usually it's done with the immunohistochemical technique, and here things are beginning to be difficult, because immunohistochemical is a technique of high level that implies high training of all the participants, and in our country we have trouble with that. Axillary dissection, we have the same basic pathology, except for micrometastasis. We think probably in axillary dissection is not necessary. Here, talking about immunohistochemical tests, we see how how they are needed for experts. You see here a review of one pathology reading receptors, hormone receptors, and a double reading. You see how change the perception of the double reading in relation with a review with the one single reading. This to name the other problem with immunohistochemical, that is the reading. You know, people that are skilled in the technique of reading this implies pathologists with a good training. This next slide wants to show how many hormone receptors are we doing in Bogota in this decade. For 2006, we have hormone therapy in 40% into 40 cases. So that implies that this is very low, hormone therapy, that we would expect something like 60–70% in these cases. So in this time, probably not all these cases had hormone receptor testing. These one here want to show the same thing. We have this series in our institute, and we received patients from all Bogota, and 10% were not assessed. And in El Country, in Bogota, in a work that was published in 2005, unknown 23%. So this is showing us that around 10–20% of our patients are not having hormone tests routinely in our country.